to the alveoli to move across the alveolar capillary membrane. Right? So we're exchanging gases. We're moving air so we can exchange gases in the alveoli.
We'll get deeper in that.
Yeah, next chapter. Sure enough. We're going to go so deep, you're going to want to crawl the other way out. Oh, mercy. How about dead space? Remember, everyone has an average amount of dead space of about 150 milliliters, and that's air that's trapped in these conducting airways that doesn't physically participate in gaseous exchange. So we understand that to be about 150 cc's for an average-sized person. Okay. What's the combination of dead space and physiologic dead space? Or dead space and anatomic dead space?
There's anatomic, there's physiologic, and there's one more.
Alveolar. Alveolar. So alveolar dead space is gas or alveoli that collapse and consolidate. You still got an open vessel. You're moving blood past that closed alveoli, but there's no air that participates in gas exchange. So there's alveolar dead space and physiologic dead space, and that's anatomic. The collection of those is anatomic dead space.
Really?
So we have to make sense of that.
It was for work.
Okay, any definitional terms as far as apnea, eupnea, tachypnea, tachycardia, not tachycardia, Biot's breathing, Kussmaul's breathing, those kinds of things. They can sometimes be descriptive and diagnostic if you pay attention to them. Okay. This chapter was all about lung volumes and capacities. So I included a short video, if you've noticed, on the A&P canvas. There's a short video for every one of these chapters that kind of expands a little bit on what the chapter talks about. Volumes and capacities is a way to help us to understand how much air there is in the airway. So when we measure pulmonary function measurements, we know that there are a combination of 4 volumes and 4 capacities. So the amount of air you can breathe in one quiet breath, what's that called?
Tidal volume.
That's right. So it's just, and if you notice, I commented on your quiz and study guide last week that at some point, remember, the chest wants to expand and the alveoli want to collapse. At some point, there's an equilibrium. So I can still exhale from that point. And even after I fully exhale, there's still some air in there. So tidal volume is the amount of air that you can breathe in and out in one quiet breath. It's what we do while we're sitting and listening to boring lectures. Right? You're breathing air in and out. You're breathing by tidal volume. It's one quiet breath, but it's also that point in your thoracic cavity that is that equilibrium between expanding thoracic cage and collapsing alveoli. So a tidal volume is right at that point where the thoracic equilibrium is set. We can still exhale a tiny amount of air from that, and that's called expiratory reserve volume. So after tidal volume, we can usually exhale a little bit of air by forcefully using our muscles and exhaling that air out. That's the amount you can totally exhale using the accessory muscles of expiration, pushing all the air out. Okay? So from there's a tiny amount of air that is always in your lungs. That's called residual volume. So we've got 3 different volumes here: tidal volume, expiratory reserve volume, and residual volume. Above tidal volume, if we breathe one quiet breath, we can still take a deep breath on top of that tidal volume, right? And that's called inspiratory reserve volume. Okay? So there are 4 volumes: residual volume, expiratory reserve, tidal volume, and inspiratory reserve volume. Those are a particular volume of air that we pay attention to. That the combination of 2 or more volumes. Now you should have answered this in the difference between volumes and capacities. A volume has is a particular volume of gas in your lungs. A capacity is 2 or more volumes, okay? So if we start taking these volumes, these 4 volumes, we can add expiratory reserve volume and residual volume. And the combination of those 2 volumes is functional residual capacity. So a capacity is 2 or more volumes, okay? Functional residual capacity. And that's just the amount of air after we exhale, tidal volume, that remains in the lungs. It includes the ERV and the RV. I can guarantee on your national board exam come next December, 1 short year from now, they'll ask you, there'll be a question on your board exam that'll ask you to make sense of these volumes and capacities. I absolutely guarantee it. What they'll do is they'll say TLC, total lung capacity, is equal to residual volume plus inspiratory reserve volume minus FRC. You know that's not an actual, it doesn't measure an actual volume, but what you have to do is be able to recognize what volumes and capacities make up other volume or other capacities. So I guarantee you'll see a question on your national board exam that'll help you to understand and make sense of volumes and capacities. There's no doubt about it. You will see one. And you'll see one on my exam. So, tidal volume and inspiratory reserve is inspiratory capacity. And a lot of times, you've all seen how to do incentive spirometry from lab. Did they do that the other day? So what you're doing is when you have a patient take a deep breath in, you're taking advantage of their physiology to expand and open up their alveoli, right? And where do you get collateral circulation through what structures to open up closed alveoli? If you take a deep breath in,
Pores of cone?
through pores of cone, you'll pop open additional alveoli. Well, what you're doing is you're taking advantage of inspiratory capacity. You're having them breathe in tidal volume and inspiratory reserve to equal an inspiratory capacity in an effort to try to expand your alveoli to prevent atelectasis. Okay? So you're really using, when you're using a spirometer, you're measuring inspiratory capacity, right? Have a patient blow all their, if you have them blow all their air out and then breathe in, that would include expiratory reserve, tidal volume, and inspiratory reserve, right? That's different than just inspiratory capacity. What would that be? ERV plus tidal volume plus IRV is this point to
Reserve
this point.
is the vital capacity.
That's vital capacity. That's different than inspiratory capacity because it takes into account FRC, it takes into account ERV plus IC. Can you see that?
Mm-hmm.
Or it equals ERV plus VT plus IRV. Right? So vital capacity is an important measurement, and a lot of times you'll measure vital capacity to get an idea of what a lung volume is, how much air they can hold. How much air can we all hold in this room, every last one of us? Probably somewhere between 4,000 and 5,000 milliliters. I'm just guessing, but we all probably have a vital capacity of around 4 to 5 liters. And that's just at the top of inspiration, blowing all your air out until you can't blow out any more air, right? You keep pushing and pushing and pushing, get all of your air out. Called vital capacity. It equals IRV plus VT plus ERV. Okay? And a total lung capacity, here's the question I asked here. Total lung capacity then would include residual volume. Okay? This amount of air you can't get out. So even when you push all the air out using your accessory muscles, the harder I blow out, the more the muscles collapse and compress my airways, right? Especially in the 18th, 19th, 20th, 21st generation where there are no cartilage, right? No cartilaginous airways. They progressively diminish. The cells become cuboidal, and we get into the single cell thick alveoli. So even when I forcefully exhale and push every amount of air out, the harder I push, the more those airways collapse. But what I'm trying to get is a total lung capacity. Okay. And even through measurement, I can't measure that last little bit of residual volume. I can't get everything out there. Some of those airways still stay open, and there's air left in that residual volume, okay? So the text pretty quickly tries to help you to understand that there are differences between males and females. You know, if we look at Armando, just characteristic, 6'9". So he's got a physical, bigger thoracic cage, and his lungs will take up more volume. We would expect, Armando, for you to have a vital capacity of 6, maybe even 6.5 liters. If we look at Megan, on the other hand, her vital capacity might be 4 to maybe 4.5 liters, just by physical difference. So we sometimes see differences between males and females. We see differences in age. We see differences in race on occasion. Blacks have somewhat larger capacity for lungs, and so they make an allowance for that. So in some of our references, at least along the Wasatch Front, there's an intermountain reference that has studied thousands and thousands and thousands and thousands of people. There was a physician here at the U of U, his name is Dr. Morris, and he measured the lung capacities of thousands of people and turned it into a table. And so we can compare people of similar age, sex, and height to people of that size, and we can predict what their volumes are. So what we do with these numbers, if we can say that Armando has a vital capacity of 6.5 liters, Megan has a vital capacity of 4.5 liters, based on age and height and sex, that we can compare then like things. And if we can compare them, then we can get a measurement or a number that seems to help us to find out if it's within normal limits. I can tell you that normal limits are between 80 and 120%. So if we expect you to have a 6.5 liter vital capacity, if you have a 6.0, that's within 80 to 120%. So granted, there are wide variables, and we compare these to normal based upon sex, age, and height, and
Oh, I have a question.
Go ahead, Armando.
I was going to ask, is it normal for people about my height to have lung problems?
Sometimes.
Because I've heard a lot of people that are my height always ask me, and like, do your lungs ever collapse? And I'm like, no, I'm fine.
Yeah. The larger structure in certain kinds of inherited hereditary disease, particularly Klinefelter's. Klinefelter's disease, you know, Abe Lincoln was fairly tall and gaunt and thin, and sometimes they have a susceptibility. It doesn't mean they always get it, but sometimes being taller height will cause bolus emphysematous kinds of collapse in the lung. Right?
Okay.
It's possible. They have spontaneous pneumothorax too,
Okay.
because of the pressures they're using to generate from a larger thoracic cage. And so the pressures in, you know, when a baby takes the first breath of life, how many alveoli are open? The first breath. First breath, all the alveoli are closed. And because the radius is very small, how much pressure does it take to pop open the alveoli on that first breath? I should have brought my balloon. You know those little water balloons?
Yeah.
How
Yeah.
hard is it to blow open a
So-
water balloon?
It's hard.
You gotta stretch them.
Babies'
Yeah.
alveoli are tinier than that, and they're sucked together because of the molecular water that's in the lungs. The fetal lung tissue is caused all their alveoli to collapse. So when a baby takes the first breath, they have to take a deep, deep breath, generating huge amounts of pressures, probably around -75 to -90 centimeters of water pressure to open up the alveoli the first time. Well, same thing with a large person's thoracic cage. They have this larger volume to pop open their lungs the first time, and it takes high pressures, high interpleural pressures and interthoracic pressures that the muscles have to generate to pop them open that first time. So it's true, there may be some susceptibility. They have some susceptibility. So volumes are dependent upon age, sex, and height. There are 4 volumes: tidal volume, inspiratory reserve, expiratory reserve, and residual volume. And there are 4 lung capacities: vital capacity, inspiratory capacity, functional residual capacity, and total lung capacity. And you should be able to recognize what volumes make up particular capacities. That'll be important moving forward. I guarantee you'll see a question or 2 on the national board exam making sense of those. The reason why we make sense of those is because when we do lung measurements, when we look at volumes and flow rates, they'll give us normals compared to people of that same sex, age, height, and race. Okay? And we'll see the normals, we'll compare the normals, and we'll get a percentage. So you're given all this data. When we do pulmonary function testing, we're not only, Jimmy, you mentioned restrictive and obstructive lung disease. We categorize changes in volumes and capacities and flow rates and categorize them into restrictive and obstructive lung disease. But we're doing it in comparison with normals. Does that make sense?
Mm-hmm.
So we use these extensively. We break it up into little bits of information, little bits of data, and then we try to analyze each of them in its specificity. Okay? And it's minute data, but we try to make sense of it, and that's really the hallmark of recognizing diseases that fall into restrictive categories and obstructive categories, is by looking at this minute data and comparing it to what's normal, okay, based upon age, sex, height, and race. Okay, the text shows you what a normal lung capacity is, and then it gives you a diagram about what obstructive lung disease does. So I'm just going to tell you quite generally, we used different colors. Restrictive lung disease, we generally see diminished volumes. So when we measure these volumes, they're lower as compared to normal. Okay? So just generally on the surface, restrictive lung disease will indicate low volumes. So every volume we measure and compare it to age, sex, height, and gender will be low in terms of the volumes that we're measuring when compared to normal. We'll get low percentages, less than 80%. Okay? When we measure, so these are particular amounts. A volume is an amount. A flow rate, on the other hand, is how fast. When I blow out birthday candles, how fast is the flow coming out of my mouth? By using muscles, I'm using muscles to exhale all of this air out, right? So that can be measured not only in the amount that I bring in, but how fast it comes out. That's flow. Okay? It's like turning on, and I think the text used an example, how it turns on a water tap. You know, you can barely turn it on where there's just a trickle of water. You can turn it way on and there's a huge gush of water. That's higher flow. When we have flash floods in the canyon, like 15 years ago yesterday, there was the St. George flash flood. And when flash floods come through, it's just a huge wall of water that washes through. And that's essentially what we're doing with measuring flow. It's a huge volume going very rapidly through a constricted, in this case, a riverbed in our airways. It's through our trachea and main stem and through our conducting airways moving out. Same kind of idea. So there is a difference between volume and flow. Very, very different in what we're measuring. Flow rates, however, when we measure flow rates, let's get this over to this one. But when we measure flow rates in obstructive lung disease, we see reduced flow. Okay. So when we characterize the difference between obstructive lung disease and restrictive lung disease, we're looking at the difference in these normals with volumes versus flow rates. Okay. Flow, you can't get the air out. So in obstructive lung disease, we create physiologic conditions that the air doesn't come out. It's trapped. And so if the air is trapped, then the flow rates are reduced. Make sense? Because there's obstruction. There's obstruction way down in the alveoli. Let me use a black or a blue one maybe. So here's the alveoli, but maybe in these 21st, 22nd, 23rd generations, we've got restrictions to flow, and so as air comes into the alveoli, you know, the main thing is creating a mechanism for oxygen to dissolve across the alveolar capillary membrane. So as air comes in, the alveoli will accept that new volume of gas. What's that called? If the alveoli accept a new volume. Remember, Alicia? Change in volume divided by the change in pressure. So when the alveoli accept a new volume, that's called compliance, how readily the lungs will accept a volume of gas. It usually does it with fairly low pressure. So air comes in, the alveoli expand, oxygen dissolves across 9 layers of tissue into the alveolar capillary membrane and into the blood vessel. And we measure that with the saturation monitor, right? And that's how simplistic the whole process is. So when we move air into the alveoli, sometimes these, you know, you've got an alveoli in front of it, you've got an alveoli behind it. It's a 3-dimensional structure. When I draw it on the board, I'm drawing it as a 1 alveoli unit. But realize you've got alveoli in front, you've got alveoli in back. And so an expanded, overinflated alveoli would do what to this airway behind it? If one alveoli in front of it is overexpanded, what would it do to the airway behind it?
Obstruct
It would obstruct it, yeah. It would pinch it closed. And if it pinches it closed, then we end up with something called air trapping. And we overinflate, or sometimes you'll see the word hyperinflation. So we have air trapping in the alveoli, the airway collapses, and then we have overdistension and hyperinflation of the alveoli. Air that's trapped that can't get out. So if it can't get out, it's stuck. And so what do patients do that have obstructive lung disease that try to get the air out? They do pursed lip breathing. Why would they do pursed lip breathing? By puckering up, it does. It keeps air back in the airways to keep the airway open a little bit longer so that some of the air can get out. So patients, you don't even have to tell them to purse their lips because they've already learned, they know that it's easier to get air out if you see smokers that have a 100-pack year history, they've smoked for 30 or 40 years, they don't need to be told to purse their lips. They've already learned how to do it. They do it automatically, naturally, because they've recognized it's an easier way to get air out. So they have advanced obstructive lung disease, and they're already doing pursed lip breathing because they've learned that it's easier to get it out that way.
So I noticed that I do that when, like, I'm exercising.
Yeah, when you're exercising.
Then I'll, like, kind of do a version of pursed lip breathing. And I never knew.
It keeps the air in longer, so the airways don't collapse, and you don't get you can get more air out. But so the difference between obstructive and restrictive lung disease is really characterized by volume and flow differences. Volume and flow differences, and we look at it in terms of these volumes and capacities and flow rates that we'll get to. Okay, flow rates that we'll get to. So they show you how air goes in and out in a normal lung. Obstructed lung appears to be bigger. Why would it appear to be bigger on this illustration on the bottom of 148? Because of this air trapping, because the airways collapse distal, and as a result, you'll see patients with increased AP diameters, right? Anterior to posterior. They'll have big barrel chests. Have you seen that in patients? Especially patients with emphysema or chronic bronchitis, or sometimes even asthma. You'll see people walking around with big chests, front to back, big AP diameters. You'll see them with prominent sternocleidomastoids. Why do they have prominent, bless you, dear. Why do they have prominent sternocleidomastoids?
Gotta use accessory muscles.
So if their thoracic cage is already expanded, how do they get air in? Yes, they're moving the chest, the capacity of their chest, and it's already expanded this way. Now they have to raise their shoulders. That's exactly why it's a accessory muscle. It helps to move the chest up this way, changing the volume so the diaphragm, and if the lungs are inflated, what does that do to the diaphragm? Diaphragms are low and flat, and we'll see that on a chest X-ray. I'll show you a chest X-ray where the diaphragm appears to be straight across. It doesn't round from anterior to posterior, and you don't see those costophrenic angles. They're all flattened, and then the heart's narrow and skinny. So, let me see if I can find one for you, just to illustrate a point. Well, some of these X-rays, you can see that I'm looking at this one up 1, 2, 3, 4 from the right. You can see how low and flat the diaphragms. There's the other X-rays that we've seen had very sharp, well-defined costophrenic angles. And it's full of air. Look how full of air this one is, and this one is, and how low and flat the diaphragms, and how narrow and skinny the heart is. I mean, the lungs are so full of air that the heart is just compressed. Look at this one right here. So lots of air in the alveoli, the low flat diaphragms, narrow skinny heart, increased AP diameter. That's just screaming at you COPD, right? So if you can find those characteristics, then you know you've got a ready diagnosis, because it hits all of the preponderance of evidence that it's this. I mean, the first question you ask any one of these people is, how long did they smoke? And there is actually one disease that produces these kinds of changes where they don't smoke at all. Does anybody know what that is? I'll just tell you, it's alpha-1 antitrypsin. So you can not smoke a day in your life and end up with a chest X-ray that looks like that. But generally speaking, 95% of the cases, if your X-ray looks like that, you have a smoking history. There's only one diagnosis, alpha-1 antitrypsin, that causes those kinds of changes without a history of smoking. Okay? But look at the AP diameter. This is front to back. This is the spine here and the sternum here. But look how big the AP diameter is. Let's see. Look how just how much air there is in all those.
The heart looks
Look at how flat the diaphragm should go far down, maybe another 2 or 3 ribs posteriorly, and look how flat that diaphragm is.
Yeah.
So low flat diaphragms, narrow skinny heart, increased AP diameter, use of accessory muscles, maybe a cough, shortness of breath, low oxygen level, that's emphysema. And it'll be that way every time.
So if you quit smoking, like, can it get better?
It's better having, if you stop smoking. And it can get better, lung function can get better, but damage generally at this point, this is years and years and years and years of damage that won't get better.
And then if you, like, I smoked for 12 years. I quit 2 years ago, but like, I wouldn't ever have any of these issues,
No.
right? Like,
Because the lungs are over-engineered. Now you're at increased risk for other complications maybe down the future, but for the most part, you did your body good by stopping and engaging in healthy lifestyles, and you can reverse some of that. But like I said, our lungs are over-engineered. If we learn one thing in A&P, it's that there's more than enough alveoli. We can survive on one lung, that there's plenty of additional space that compensates for any damage or imposition that we place upon it by behaviors that you know, in this case, bring smoke in and damage the lung, the lining of the lung.
So like the one
It
thing
can get
that,
better.
one thing that can't be reversed is the pseudostratified glomerular
Yeah.
epithelial cells, right?
Yeah, there might be a cough, but you won't generally regenerate ciliated
Right.
cells. Yeah. So that's an extreme case, and like I said, we're over-engineered, but we don't notice residual damage until the behavior continues years and years and years and years and years, and then there's these kinds of changes over that time that result in non-reversible kinds of damage. So that can get better, but in general, usually the time we catch it is after 20, 30, 40 year history. And now they've got a cough and they're seeking medical attention because they get short of breath crawling up one flight of stairs. And so that's getting back to that chest x-ray and this alveoli and air trapping and hyperinflation. Can you see what that looks like? Hyperinflation and air trapping. So it's pretty specific. Full, lots and lots of air. How dark that was. I wonder why that was that color. All right. So obstructive lung disease, it appears bigger because there's more volume. In fact, what happens is can you see this? The line that I've drawn there, tidal volume, inspiratory capacity, vital capacity, and then back to baseline. So obstructive lung disease, you can see inspiratory capacity gets a little bit smaller, tidal volume might get a little bigger, expiratory reserve stays about the same, but what really increases in obstructive lung disease? Residual volume, that's the amount of air you don't have access to. You can blow all your air out. So the amount of air that stays in there, residual volume actually increases. So that's where you're changing volumes is that the residual volume gets bigger and bigger and bigger. Instead of 100% of predicted, it ends up 140, 150% of predicted. And that's air you don't have access to. It's air that keeps the alveoli open, but it also reflects the air that's trapped that can't get out. Okay? Residual volume. Restrictive lung disease, what happens to the lung in comparison to normal on the next page? It gets smaller. It gets smaller because of decreased volumes. So usually, the best example I can give you of, so the best example of obstructive lung disease is emphysema. The best example of restrictive lung disease is kyphosis. So if you have a scoliosis that curves your spine or a kyphosis that makes a humpback, if you can compress, in this case I'm compressing my left lung by turning over to the side. So do that and try to take a deep breath. Now sit up straight. Can you take a deeper breath sitting straight up than you can moved over to the right or the left? So that's a reduced volume. That's a reduced volume. So what we do with restrictive lung disease is we mechanically restrict the amount of air that the lungs can get, either through a curvature of the spine or from almost all the other pathologies. Usually what we say is that in obstructive lung disease, we've made this mnemonic before, right? CBABE. Cystic fibrosis, bronchitis, asthma, bronchiectasis, and emphysema. All those diseases are obstructive lung diseases. They're characterized by reduced flow rates. Everything else is residual. All the other pathologies that Kelly's talking about all the diseases result in restrictive lung disease. Pneumonia, pneumonia, sarcoidosis, all the other lung disease, pulmonary embolisms, all of those produce restrictive effects by minimizing the amount of volume you can get into your lungs. So for PFTs, we like to stratify and distinguish between obstructive and restrictive disease. Obstructive disease is indicated by reduced flow rates. restrictive disease produces reduced volumes. Okay, so that's the take home. So that's where they talk about obstructive disorders versus restrictive disorders. Okay, so most of these volumes we can measure through something called simple spirometry.